you're planning to speak for about 40-45 minutes. So there'll be time at the end of that for people to ask Debbie any questions that they might have, or just start a discussion. So it'd be great if you could pop any of those questions or queries in the chat. So thank you again for coming along to the seminar, and I just want to briefly introduce Debbie. Debbie is a wonderful person who I've come to know over the last few years, a person who is multi-talented. She is a critical care nurse by background and the Associate Head of Simulation at Sheffield Hallam University. She's had a long-standing educational role where she teaches about patient safety, human factors and quality improvement at both pre and post-registration level. She also did a secondment to the Yorkshire and Humber Improvement Academy a few years ago, where she worked on regional projects in the field of human factors and patient safety, and that's where I first met Debbie, and she expressed an interest in doing a PhD within this area. And then Debbie was very focused and dedicated to the cause of getting funding and support to do a PhD, which she did, and she recently completed that at the University of Leeds. And it's that work that Debbie's going to talk about today, where she's taken a resilient healthcare lens to explore the topic of workarounds and safety. So Debbie, without further ado, I'm really looking forward to your talk today. Over to you.
Thank you, Rebecca, and thank you for inviting me to come and talk about the research I completed as part of my PhD. It's a privilege to be with you all today. So I completed my PhD this year, so some of this work obviously is not published. I look forward to doing that in the future, but I'm going to talk to you about the overarching project, and then, like Rebecca said, at the end we'll have time for some questions. So in a nutshell, my PhD project explored if, when and why healthcare staff work around those safety standards that have been put in place really to create safety. And I really wanted to understand if workarounds could be used to improve care. I think this desire to look at this topic came from my clinical background initially. For any clinical people in the audience, you know, we recognise readily really that work is not always done how it is written down in policies and procedures, and much of our time is spent navigating that space. And I've questioned really what this means for safety. And on one hand, and certainly historically, not following standards has been seen as a violation and as detrimental to safe and effective care. But on the other hand, and certainly through a safety 2 perspective or a resilient healthcare lens, which views healthcare as a complex system and safety actually as the ability to succeed in varying conditions, these very same policy violations that are possibly detrimental or seen as detrimental might be useful and might actually be helping us to create safety for patients. So that's really what I wanted to understand more about with this work. This didn't sort of come out of nowhere. Obviously, there's lots of literature that are beginning to talk about that, and very much we've had in the past policies and procedures as the cornerstone of reducing our variation and increasing reliability. And I'm certainly not saying that isn't important with this work, but I think there's possibly some other areas we need to look at as well and explore if the use of workarounds is in any way useful to us. So that's what I'm going to talk about today. To try and address the aims of my research, I came up with 4 objectives to address the overarching question about when it's safe to work around a protocol. So I'm going to, through this presentation, I will go through each piece of work or each project really that overarchingly fitted into the PhD. So firstly, I wanted to explore the empirical literature to understand what was known about safety standard workarounds already and what was being written about in the literature. I then moved on to choose an exemplar practice where risk within healthcare is being managed using safety standards and explore if and what kind of workarounds are being used in different healthcare settings. I then use that same exemplar practice to investigate what kind of similarities and differences are in the workarounds and to try and see what the workarounds are achieving and why they're being used. And then the final study was aiming to understand what multi-level stakeholders, so this is people at different levels of our healthcare system, how they perceived workarounds, and explore if there was any potential for operationalising the safe use of workarounds in practice and within policy. So that was how I sort of structured this work, and that's the way sort of I'm going to look at it with you over the next 40 minutes or so. Okay, so as I mentioned, the first piece of work really was to do with exploring what is already known about safety standard workarounds in healthcare and what is being written about in the literature. And reflecting back on this journey, I found this review really challenging. Both the term workarounds and safety standards are really poorly indexed in the literature. And I'm maybe sure with everybody's PhD, it took a while to get this going and to feel like I made significant headway, I think, really with this. But it was a really useful grounding for the work that went forward. So I conducted a scoping review following the guidance from Peters. I developed search terms using the PCC structure and search for my the terms and the synonyms within the Medline, CINAHL, PsycInfo and the Web of Science. The search resulted in, and using the inclusion criteria obviously, resulted in 27 papers going through into my review, which I was able to use to try and answer the questions I'd set. And I used a narrative synthesis using the guidance by Pepe to try and collate that information and draw that information together. So the overarching results from this review, as I mentioned, was 27 papers were included in the review. Across those 27 papers, rather helpfully, there were 23 varying definitions of the term workaround. And like I said at the beginning, it was very difficult to sometimes understand if we were talking about the same thing when I was thinking about what even is a workaround. Most people prior to 2018 were defining the term workaround, suggesting, I think, that we're not clear on what we mean by the word. But after 2018, that seems to settle down, and there does seem to be a bit of a shift, and that people are aware of the term and are using it. But it was certainly not uncommon to see definitions related to what you mean by workarounds within the papers. I found within the review that 21 different safety standards were reportedly being worked around. So that was quite a range of different standards, but over half of these studies were talking about working around standards relating to medication safety. Sorry, skip that there. Talking about working around the standards relating to medication safety. Consequently, we sort of saw, or what I saw in the review, is that the people who were working around were more likely to be nurses, doctors and pharmacists. But I think that was a consequence of the fact that medication safety was reportedly being described within the literature. The reasons people were working around the safety standards largely were organisational. Within that umbrella term of what an organisational reason might be, I drew upon the literature to create a structure, but that could have been things like there being too many policies, the policies being ambiguous, the policies being contradictory, fell sort of within that category, and people described that fairly clearly in the literature. The task being used because of the task, and people choosing to take the shorter route of doing something if possible to increase the time. Patient factors, so patients wanting or not wanting certain things to happen, what would lead the staff member to work around part of the policy or procedure. There was features of individual clinicians making choices to use workaround based on individual things, which included things like cognitive load, fatigue, and skills and experience. And then there was a strong sense of professional factors that came through as well, and that could be professional boundaries. It was not uncommon to see quotes or phrases such as, "That isn't part of my role, it's somebody else's," even though the policy would be directing it. It could be to do with decision making, and to do with, "This is part of my professional responsibility, so I'm choosing this over this." And sometimes there was a tension between people's professional responsibilities as they saw it and what is written in an organisational policy, and that came through in some of the papers. I had been hoping with the review to understand the implications of the workarounds and what they were actually achieving in practice, but that was really difficult. I tried to achieve that by looking at the Institute of Medicine's definition of quality. So I was looking at, are they workaround, what are they achieving for person-centered care, for safety, for effectiveness, for efficiency, those kind of things. But that was really difficult to do. But what I could, and I couldn't really come up with a clear understanding of what the workarounds were achieving for safety from the literature, which suggested the further work that followed in this PhD was required. But what we could see is that the implications were multifaceted. So the workarounds were achieving different things for different people. So it was perceived that the workarounds were being used to benefit patients more often than they weren't. It was perceived that the workarounds were helping staff, and that was often in terms of balancing workload and looking after multiple patients rather than just one individual. And there was also the suggestion in the literature that the workarounds help organisations as well by allowing care to happen, but without us having to say, do this or do that in these circumstances. It allowed a bit of a grey area that was maybe beneficial to organisations. So those things came through, but it wasn't really clear what safety implications are. And some of the studies were reporting that safety standard workarounds were supporting resilience in some circumstances, but I think it's important to say that some other studies were saying the opposite and saying that the safety standard workarounds were detrimental to safe care. And sometimes it was both. They were saying they were safe and they were saying they were not safe, all at the same time. So taking that as a platform, I sort of moved forward, and what was really useful for me for going forward was determining a definition for what a safety standard workaround is, so I could go forward, and hopefully this is useful to other people. So based on the review, I defined the safety standard workaround as an adaptation, improvisation, or change to an existing work rule designed to promote safety, in order to overcome or lessen the impact of obstacles that are perceived as preventing the work system or actors from achieving a desired goal. And that's how I proceeded using that definition as things went forward. So moving into my second study, I was keen within this work to explore what workarounds look like within different healthcare settings. And I conducted 3 single case studies within 3 different sites using focused ethnographic methods and then constant comparative analysis to understand what was going on. So Charles Vincent and René Alberti have developed a framework that is often cited in some of the safety literature about how different settings will have to approach safety differently according to the type of work they do and the challenges that they face. And they categorise these in 3 different areas. So they suggest that some areas will be ultra safe because they're able to control their work that they do more rigorously than anywhere else can, and they will only proceed to do their work, deliver care in this circumstance when certain criteria are fulfilled and when conditions are good. So that's an ultra safe setting. The high reliability is the middle space. That is where there's policies and procedures in place. There's a fairly high level of predictability and control that can be applied to this setting, and they will manage safety in that space in accordance with that kind of way. And then there's an ultra adaptive approach, and that is where there is a need, because of the uncertainty and challenges presented, to take a more ultra adaptive, so adapting in the moment to the circumstances people find themselves in. So using that framework as a guide, I selected 3 very different case study sites to go and explore one exemplar practice, because in an organisation, a healthcare organisation, we would have quite often the same set of policies and procedures being used across all of those sites, but being expected to fit in much the same way. So I know that most of us would probably think about this and think, well, there would always be some local adaptation, and for sure there is some local adaptation, but when is that a workaround? What is that achieving for safety? It was part of what I was trying to understand, and this really helped me to maximise the variation and sort of be able to explore this with some kind of structure. So I selected a haematology ward, an elective surgical ward and an emergency department to undertake my case studies, and was fortunate enough, working in partnership with partners, I was able to recruit those different sites from one organisation to work with me, which was really, really helpful. For my case study site, I sort of mentioned at the beginning I was going to choose one exemplar practice. So I spent a lot of time thinking quite carefully about that and having conversations with people, really. And the practice I just chose to focus on was the IV medication administration being enacted by registered nurses in these different healthcare settings. And I selected this practice for a few reasons first. Really. Firstly, evidence. There's loads of evidence that medication safety is an ongoing issue within healthcare, so there's relevance and it is important. Working with people from different clinical backgrounds across a range of organisations in selecting these standards, this came up as a common concern that they thought if we could make improvements in this area, that would be really useful. So I wanted to try and do research that was useful. For me, it was important that there were clear standards which govern this practice, and for IV medication administration, that is the case, so that was really useful. And then I also held meetings with patient partnership groups to discuss whether studying this practice would be acceptable to patients and their relatives and carers. Yeah, this was thought to be acceptable and nothing that would upset anyone or cause any challenges. So that was the practice I decided to proceed with in this work. Okay, so having determined the sites, determining the practice I was going to be looking at, and then aiming to explore when, how and why registered nurses work around the safety standards that that inform IV medication practice, I set out to sort of try and understand if these workarounds, what they were achieving, if they're happening, and what was being achieved. So I've just got 3 images up on the screen which reflect my case study sites. For anybody who's done ethnography, you spend a lot of time getting excited about the prospect of, certainly myself and some of my colleagues who I spoke to, being excited about getting into these sites, and then you turn up on your first day and it's like, oh blimey, nobody's going to talk to me. So I had to learn quickly really about how to talk about my research in a way that was acceptable to my participants and help them to engage, because just if I came into an area and said, I want to watch what you're doing and I'm interested in things you do when you do it outside of the protocol, it might sound worrying and concerning. And I needed to work on getting that messaging right, really, at the beginning. And very much, I've been a nurse for a long time and I grew up on this kind of thing. Well, I know we have to do some things over here that I would rather people weren't looking at. So I knew there was an issue with trust and making sure I could, work with them in a way that felt supportive. And so I spent a lot of time at the beginning hanging out, getting to know the flow of the work, and I sort of termed these in my ethnography as just general observations, understanding the flow of things, what their day-to-day looked like, and just having really casual conversations with all of the staff and with all of the any patients who were interested about what it was I was doing and why I was looking at that topic. And I very much approached that from the position of, I want to understand how you do well when it's difficult, because there was no suggestion that any of these areas had any particular issues with this practice. It was more that we all know this can be challenging. How do they solve those challenges day to day? And that definitely helped with people accepting this was genuinely exploratory work, and helped people, I think, to be able to share with me. There were setbacks for sure. I can really remember probably about a week into my first site, a member of the medical team saying to the nurses, watch your back, she's going to try and catch you out. And I was really taken back, and I was like, no, I'm honestly not trying to catch people out. I want to understand how they're succeeding when it's hard. But just a negative message like that was really difficult to get across. And it's not something I've designed, but I think it's Marie de Vos talks about using marriage and as an analogy, and will say, if you want to understand the secret for a good marriage, a successful marriage, who would you study? The people who are happily married or the people who are divorced? And would study those who are happily married. So I would say to the people I was working with, I'm happy, I want to study how you're doing it right, not because you've done something wrong. And over time, using that analogy seemed to help with them sharing with me. Okay. So that's some of the challenges. I managed to collect quite a lot of data in each single site. I think I collected, I'm just scrolling down some of my notes. Yeah, I did about 80 hours of observation, general observations in each site. I did about 40 focused observations just on the IV medication administration, and between 5 to 10 interviews in each different site. As I was gathering the information. And sometimes I would go back to different sites. If I saw something happening in one area, I'd go back to the original, the first site I went to go and explore if that was also happening there. So I had a lot of flexibility to move across the areas, which I'm going to talk about more if anyone's interested. So really within this presentation, I haven't probably got time to go into too much detail about what I found within each case study site. So I'm just going to pick the middle case study site, the high reliability setting, and I've put up on the screen the themes of what came through when I got into the analysis of what I saw. So to do the analysis, I drew on my observations, my conversations, focused details about the how IV medication administration was being enacted, and drew all that together looking for what was novel and what was interesting. And that work took a lot of time. I had a lot of data in each different case study site. I also did a documentary analysis, so I collated all the policies and procedures that were relevant to the practice within the organisation, and that had been drawn from my participants telling me what shapes their practice and what they do. And then I looked at the workarounds or what was novel and interesting, and then related those to the policies to try and determine what the workarounds were, and had conversations with my participants about that as we move forward. So the three standout themes that came from the high reliability case study related to e-prescription workarounds, double check omissions, and routinely mundane workarounds, which were happening all of the time. This picture at the top was drawn very kindly by a lovely artist who I spent time talking to about the things I'd seen and things that were going on, but I think it really nicely captures what life was like for the nurse trying to administer IV medications in that site. It will therefore come as no surprise that people weren't using the online e-prescription system as detailed in policies and procedures. There was locked doors. They had computers on wheels that couldn't roll very easy along the corridor. They had lots of other things to have to carry, so they would often be either carrying a laptop. So it'd be no surprise, probably, if you're looking at that picture going, what's the one thing they're going to put down? They put down the laptop, and they were working off a piece of paper in their pocket. So that was not uncommon. So they were really interesting workarounds for me, and there were questions about what is that achieving? But that was really quite, it's just what was happening. It's happening everywhere across the organisation, really, but really apparent in that setting because of the equipment and the layout of the ward in part, and because of staff preference. There was lots of different reasons for that, and I'll go into that in a minute. The second workaround, double check omissions. So I know the Yorkshire and Humber Group are interested in double checks at the moment, but certainly within my research in this site, there was a requirement that certain IV medications needed to have a double check before they could be administered. And I don't think that's uncommon across other organisations. Occasionally, that part of the standard was worked around in the high reliability site, and the time I saw that being worked around that had particular significance was when the ward was very short-staffed. The nurse had tried to get somebody to come and help to perform a double check for a patient who was really unwell actually, and they just had a medical review and needed their treatment quite urgently. Nobody came, so in the balancing the risks that the nurse said, I know this medication, I know this patient also, I'm going to administer it, and chose to work around the policy. But what was very interesting and what was very difficult for the nurse in this site, that appeared burdensome. They felt as though they were doing something wrong, and they said, yeah, it's really awkward when these kind of things happen. But actually, and it made me think that if another nurse on a different day might not have made the same decision, that might have been detrimental to patient care in another way. So that was a really interesting for me to want to look at. And then there were these routine and mundane workarounds, I would call them. So things to do with wearing gloves was kept featuring. Wearing gloves or not wearing gloves. Nobody seemed to be able to, you know, people would do that or wouldn't do that. Labelling of medications, pre-preparing medications, things that were just happening frequently and didn't seem relevant to anybody, but these things were in a policy about how you should do something. So I was keen to explore, well, if they're not important, should they be there, or what was going on? So they were the three things that really stood out from that case study site. And there were different factors that obviously were relevant as we moved on. So once I determined what the workarounds were and what was happening and had discussed those with my supervisory team and with the sites I was working with, I started to explore the causes, and I used a framework that had drawn from my scoping review, really, that was based on the work of Koppel, Deb de Bono, and then there's the paper that we wrote about these different factors which are causing the workaround. So then I was looking really deeply, trying to understand what is triggering these workarounds within this site. And then I was trying to understand the type of workaround that is being used to overcome the barrier or the problem. And this drew heavily on some of the work Rebecca did and James Reason before. That was actually, I think, throughout the PhD became more important. We'll pick up on this as we move forward. But really, this work was sort of saying that there are routine workarounds that occur when there are shortcuts between 2 points, and people take those. You know, everyone's busy, so routine ones. There's optimizing workarounds that generally occur to optimize the work situation. And I think in the original work that very much came from for personal gain. So how can I make this either more enjoyable, more interesting, or in some way better for me? In my work, that wasn't really the case. It was more optimizing the task either for patients or optimizing the task for work colleagues. So that was people doing things outside of the policy to make it better for other people, really, but still optimizing. Situational workarounds, though, in the original construction of this, we were talking about organisational failings triggering the need for the workaround, and I saw quite a few of those kind of things. And then truly exceptional workarounds which only occur in a particular set of circumstances, and it says here abnormal or emergency, and are rare. And across my study, really I only saw one exceptional workaround. So it was quite interesting that original work on violations translated really well into this work on workarounds that I was doing. Okay, so the summary, really, just to summarise some of the single case study findings. I found that this single task, IV medication administration, can be associated with multi-safety standard workarounds. So from recognising a patient needs an IV medication through to administering it, there could be a multitude of workarounds that are happening. It's very rarely would be just one. There could also be no workarounds at all, but yes, it would very rarely be just one workaround happening. I could sometimes be trying to scribble things down really quickly because so many different things are happening. Safety standard workarounds being caused by a multitude of factors. So again, very rarely just an organisational cause. There's possibly other things in there as well. So they're complex to understand. And really from the analysis, I could see that exceptional situation and optimising workarounds can all become routine if the underlying cause for the workaround is not addressed. And that became important later on. I also found that some safety standard workarounds are common across all settings and others are not. So some things wouldn't happen in some of the case study sites for various reasons. And that was really really useful as I move forward into the next part. So my next study, I was really trying to understand then, okay, so these things are happening. They're happening in all the case study sites. They're very different. They've got lots of different causes and there's different types of workarounds that are being used at different times. But how can we understand how these workarounds are affecting safety? So I was really approaching this question from the safety 2 perspective that I mentioned at the beginning. And I've got the definition I drew quite heavily upon. This is the Hollingale definition from 2013 that talks about a system's ability to adjust its functioning prior to, during, or following a change or disturbance, so it can sustain the performance under both the expected conditions, the day-to-day, and the weird and wonderful under unexpected conditions. So I was really trying to look at it from that perspective to try and see if these workarounds have got value for safety. So for the multi-case analysis, I had got a whole host of data from my single case study sites. I drew that together to create the themes that were relevant and interesting to look at, because obviously I couldn't look at all of it in lots of detail, but I could be really focused about it. And there were 4 main themes that I chose to focus upon. The first theme has been described as between a rock and a hard place, and this was these double check emissions which were happening across all the different sites in some way, shape and form, and warranted further investigation. What was interesting to me about this is that the workaround I told you about in the high reliability side seemed to burden the nurse quite heavily, and there were questions about that being a reasonable thing to lay on an individual. There were questions for me about what would happen if somebody made a different decision. There were questions for me about what if something had gone wrong in that circumstances. But I went to another site and they quite commonly admitted the double check because of workload pressures. And what they would do is save the medication files and perform the double check retrospectively and enter the data then into the electronic prescribing system to evidence that they'd done the check. And that was how they worked. So it didn't seem to be causing any stress at all. And they would only do it when there were pressures in the department, but what was prioritised was efficiency in getting medication to patients on time. That was interesting. And then in another site, there was an area where they said that they would work around the policies if they this policy if they needed to, and they perceived that they did, but I never actually saw them do it. But they all talk wholeheartedly about needing to do it sometimes. So it was something everybody recognised. And there was some controversy around this. So again, I thought, well, I've got all this data. To do it justice, I need to look at it. The next area of focus, again related to workarounds I'd seen across all case study sites, but in different ways, was changing the route of medication administration from that was on the prescription chart. I think this was a bit controversial, certainly for some people, and certainly when we went through into the stakeholder group, but the times when this was being done, again, was very different in each case study site. So it was really interesting to unpack and try and explore more. Then moving into, I decided I wanted to look at a couple of things that seemed to have a big impact within the organisation, a couple of workarounds that had a big impact in the organisation, but were probably hidden, because I thought maybe this would expose some of the difficulties with workarounds in an organisation. So the first category was double trouble, which related to duplicate e-prescribing systems across the organisation. Which was really interesting. That was in one site, would have 2 different systems that had electronic prescriptions on it, and the nurses did so much safety work to try and create safety around that system that benefited the rest of the organisation. So that was very interesting. And then the other one, tricks of the trade, was using IV flush lines to give post IV intravenous medication, and that was more of an innovation and was seen to be a better way of doing things. So I took all of these 4 themes and then used a framework by Siri Wig and colleagues to try and understand what these workarounds were doing for safety, and that was formed part of the analysis. And just in the interest of time, I'm going to skip along here. So there's a table here that is showing sort of what my main summary of the main findings really were. And that was that the double check emission was creating a form of resilience that created safety in the circumstances when I saw it being used in all sites. The medication route change, it created an improved experience for an individual patient, but it introduced the potential for potential to decrease safety. In the ultra-safe site, the medication route change certainly created safety. And in the ultra-adaptive site, this was largely related to medications not being available in the form that they were needed by the nursing staff. So it was seen to be better than doing nothing, but by no means perfect. So a situational workaround really that was becoming routine because of inaccessibility to certain medication. The duplicate prescription system, interesting here. So in the ultra-adaptive site, it was certainly degrading safety. It was taking nurses away from doing other things that they needed to do, but it was creating efficiency and safety across the rest of the organisation. And I think that is going to be a really challenging thing to resolve. And then the intravenous flushes, it was only been used in one of the sites, and very much it seemed to create safety and efficiency. So might be seen to be the golden ticket. I don't know. Okay, so I had basically drawn together the data that was suggesting that some workarounds, safety standard workarounds in certain conditions were supporting safety, but there are other safety standard workarounds that were possibly not creating safety and could be argued to be detrimental. I next wanted to go to experts to have conversations about this and to think about what we should do about these workarounds and how or if we should operationalise them to support safety. So the final study in my PhD was a it was a focus group, online focus group study. So I ran focus group with senior leaders from across the healthcare system. So people from a range of professional and regulatory bodies. I then ran a series of focus groups with people who had responsibilities for safety at an organisational level, and then I ran some focus groups with frontline nurses who worked in similar sites to the case study sites. They weren't from the case study site I went to, but they were from settings very similar, so they had deep perspectives on some of the work that was being done. And we explored the workarounds that I've just presented to you from the multi-case analysis. We explored those within our conversations to understand whether they thought they were useful or whether they should be supported, could be supported. I just thought I'd share a little bit of the raw data with you today. So workarounds were perceived to help sometimes patients, sometimes nurses, sometimes the teams, sometimes the organisation. And in those instances, the people in my focus groups, participants, were keen to find ways to support certain workarounds at certain times. I'm not going to read those out to you. I'll skip on. And then specific times when the participants thought the workarounds were useful was when adhering to a policy was perceived to result in less effective care. And there were hearty conversations in each of the focus groups around that balancing act. Working in challenging conditions, that was another time when people felt workarounds could be used, and there is a need to balance risks. So it was widely recognised that very rarely are people just trying to hold on to one risk. They're obviously trying to offset a few at the same times. And some of the quotes there were really powerful. And this was coming across at every level of the healthcare system. So frontline nurses, managers, hospital managers, and right through to the top level of the healthcare system. And some of the things that came through were really surprising to me. You know, this quote, that's not what the standard says, but no, you've got the patient in front of you, you're using your eyes and ears and your clinical knowledge, and that takes precedent over the policy. That was those quotes, the ones in blue, are coming from senior levels of the healthcare system, suggesting this should happen and be enacted. But actually the reality of doing that is really challenging for nurses in organisations who aren't being asked to work in that way, because maybe we don't know how. So, drawing together a summary of the focus group findings, there were two standout things I just thought I'd mention to you today. And that was really one, that what do we even mean by safe? It was as though there were two different safety narratives going on. One, that safety is created through following policies and procedures. And I certainly have people in focus groups saying to me, well, they didn't follow the policy, so that's an error and that's no good. Even though they could understand not following the policy had created safer care than following the policy. It was a real tension in some of the groups that was led actually a couple of participants to contact me outside of the focus groups to carry on the conversation, because they were saying, I didn't want to say that in front of that person, but sometimes that has to happen. So that was interesting. What do we even mean by safe? Can we reconcile safety that's created through policies and procedures and a need for flexibility and adaptation? Because that was the other side of the argument. How do we support safe adaptation? But not all adaptation is safe. And the participants certainly weren't thinking that either. So how do we draw that together and move on was really interesting. So that was really around, you know, conceptualization of even what safety is, and then how do we walk this tightrope of, if we want to be flexible sometimes, how do we be flexible and how do we make that flexibility safe, especially across an organisation? And then how do we learn and how do we improve? And I think what was really pivotal and what came through was that there is a need to distinguish between the types of workarounds. All of the participants at every level of the focus groups are able to talk about differences in the workarounds, and they could see the differences acutely. So very rarely were participants comfortable with routine workarounds, so these shortcuts between one point to the other, and felt that these generally were degrading safety. And that would possibly align with some of the theory that talks about organisational drift, really, and erosion of standards over time. So in those situations, the participants in the focus group talked about the need to relook at the policy and either remove the things that are unworkable from the policy or enforce them, and make sure that they are important and that it can be enacted. Situational workarounds, they recognise that may contribute to safety in some conditions. The main worry with situational workarounds is that they just become routine, and because we don't fix the underlying problems, and that is a real issue because we've found a shortcut and we can carry on, rather than finding and fixing the problem. So people very much wanted to be able to talk about these situational workarounds and resolve them. Task optimizing workarounds. These were seen as potentially a source of innovation and need to be considered and possibly supported, and could be formalised, so they'll go away, but maybe there's some merit in looking at those in more detail. I think just leaving these task optimising workarounds, from the examples I saw within the research, just leaving them as good as they are in the system without formalising them creates other problems, and that came through a little bit if you don't try and formalise them. And then exceptional workarounds. Maybe we should be supporting some flexibility around this. So this was like, how can we allow people to be flexible at certain times? And this led me really to, developing this mnemonic, really, that maybe suggested conditions when it might be safe to work around a safety standard to provide safer care. And this all came from this focus group data. It was felt that it was probably safer to work around the standards when it was clearly in the best interests. When it was safer to work around a standard when we were aware the workarounds being used. So this isn't being absent-minded, oh, I forgot to do that bit. This is, I'm consciously choosing to do this because of X, Y, and Z. It's an urgent situation, so there is no time to do the find and fix, and you need to do something else about it. We can't just be left. They felt it was safer if it was in a specialist area, so other mitigating solutions could be put in place. And there was an experienced team or an experienced nurse was more able to work around the standard. So this hasn't been tested. That was really just as far as I got to in this PhD research, but it is something I'll be interested to look at in the future. So I think really in conclusion, I found this quote from one of the participants in the focus group one motivational and really sums up the whole thing. I think the worst thing we can do about workarounds is ignore them because they give us so much information. The research was successful in achieving what I'd hoped it would do, and I think the key messages really from the work were that certain safety standard workarounds are a form of adaptation that supports resilience and can create safety. But on the flip side, there are other safety standard workarounds that has the potential to degrade care quality and can diminish safety. And because of this, we really need to make sure we're managing workarounds and not ignore them. My big finding really that was interesting to me, that workarounds are recognised by people working at all levels of the healthcare organisation, and they're ready and they are able to use these insights to make suggestions to improve care. But I suppose I do worry that without a culture or an infrastructure that is asking us to go looking for this, we're probably not going to reach much improvement. And I'm going to finish there. I'm sorry if I've gone on a little bit too long.
Thank you so much, Debbie. And can we have a virtual round of applause, please, for Debbie? Thank you. We do have, Debbie, a lot of questions because it was such a fascinating talk that raises so many just interesting issues around balancing risk and compliance, autonomy and and compliance and so on. So I think if we could go to the chat, shall I read out some of those questions, and perhaps you could have a go at
I will have a go at answering them. I can't
later.
say I know everything, but I'll try. Yeah.
Perfect. So Jenny, Bryony, and a few other people started us off with questions that were really around the relationship between workarounds and kind of safety clutter, or stuff that's not really achieving safety. So Jenny said she's really interested in the overlap between workarounds and safety clutter. How many workarounds represent clutter? Are workarounds a potential source of clutter? She says she's not expecting an actual answer, but then later Bryony says, or are workarounds a response to safety clutter? So something around that, Debbie.
Definitely. And there was, I certainly drew upon the work of Ray around safety clutter in part of my PhD. And I think, to be honestly, it's a bit of both, because if you're creating a shadow system in order to make a system work, that is arguably clutter, isn't it? But if that's the only way that the work can be done, you know, and I think what came through, I'm just sort of reflecting back on some of the things. So I talked to in some of the interviews, participants would explain, oh yes, well this happened, so we have to add this part into the policy. And I certainly know that in Ray's work, they talk a lot about how policies just grow and grow. They don't ever get cleaned and filtered, and that came through an awful lot. And actually, I think one of the things, and I don't know whether it's right or wrong to do this or have this in a policy. I've got no, you know, I've not really investigated this area, but was around the cleaning of vials and ampules before doing it. And you know, I've got people from every different setting going, if I actually followed the policy on this, it would take me, I think it was 5 minutes versus 30 seconds during the administration part to give the medication. So that would be clutter. That actually, when I went to the infection control teams and said, what do you think about this, people are saying, and they said, yeah, we know that doesn't get done, and it's probably not very important. So for me, why make people feel bad about not doing it?
Yeah, really good point. And that aligns with Jenny's next really important question as well, which is around, we introduce new policies, but we don't introduce them necessarily with the goal of testing them and then taking them out if they don't work. And could one way of testing a policy be to see how much it gets worked around, or the problems it causes when it's introduced into the system?
Yeah, so that came through within my research about very much in terms of introducing e-prescribing systems. Who ultimately has the responsibility for that? So you had lots of different parts of the organisation looking after certain parts that only came together and was enacted with a small bunch of clinicians essentially, who couldn't enact the policies in the way that they were designed to be used. And so, with part of my ethnographic inquiry, I was going back into all these threads and going, oh, what about this bit? And they'd say, oh, well, that's not really for us to resolve. That's what we want them to do. But yeah, it was how these things all come together. And if they're not working, they just seem to get left to linger, and people find a way around them. And the systems aren't working, I don't think, in any way that they should be.
Thank you, Debbie. Naomi asked a question next, which is around in terms of thinking about the balance of workarounds to kind of compliance. Could you say anything about that? Was it, people were complying 50% of the time and working around? How did that look on the wards, or was it different across the three sites?
Yeah, so I think what was surprising to me was the workarounds were probably just as numerous, but they were different. So I wasn't really looking, I wasn't trying to to count the number that were happening. It was more that they were just different in different sites, which I think is interesting and reflects possibly different pressures, different access to equipment and technology, different levels of experience within the healthcare team. I think all of that had a part to play in the number that were happening. I do think you could get rid of an awful lot of workarounds. So you could shift compliance, you could increase compliance by addressing the cause of situational workarounds, by making the task optimizing, they could become, get written into the policy. You could manage the routine workarounds differently. So actually, I think it's only the exceptional workarounds that actually is where you'd need to create the flexibility, but it's just having the impetus to do that work.
Thanks, Debbie. And then Will asked a really interesting question around at what point in healthcare professionals training do they need to learn about workarounds, and do they need to learn how to do them safely?
Yeah, so this is something I'm wrestling with. I mean, I certainly think one of the recommendations in the final section of my thesis, I talked about the need to help people understand safety from different perspectives, and that it can, there's safety through that is that I've grown up with, that is through policies and procedures, but I think we do need to talk about how safety can be created through other mechanisms as well. I work in this space, don't I? So I work with lots of people who are going to be new registrants, and people who are in established careers, and I'm cautious about that. And I don't know what we do, but I think there is an argument to look at that in more detail.
Thank you. And then Jane asks, she likes your term hearty conversations, by the way, but she also asks, did you find that workarounds were more often done by more experienced staff?
Yes. I'm just thinking through the different sites, because it was all slightly different in different sites. Yes, and it was maybe the confidence that they used them with, that they did them. I also think, so I spent a lot of time, when I initially started doing this work, it was hard to understand what was intentional and what wasn't intentional. So Rebecca will remember frequently, I don't know if they're doing it on purpose or not. So we spent a lot of time discussing that, and certainly the intentional ones are when people were more experienced.
Okay. And Gary's might want to have a chat with you about some of the links he's seen between organisation data confidentiality protection and policies, which might be an interesting comparison. It's a great topic, really fascinating in the chat too, Debbie. And then Lizzie Sweeting, who's got a strong interest in just culture, is asking about do you think that people would talk differently or be so open about workarounds if there was a poor outcome? So I think you mentioned earlier on, didn't you, that if there's a poor outcome, then presumably people would get blamed for a workaround.
That is the big risk, isn't it, of leaving them? So I don't think they would talk as openly. No.
Yeah. Lots of fascinating. Okay, I'm looking at the questions and thinking we've nearly got through. Oh, one from Beck here. Do any organisations inform policy revision through exploring workarounds at the moment?
Not that I'm aware of, but I have been contacted by some organisations who are interested to talk about this. So, yeah.
And she refers to landscape architects who now do this by allowing desire lines to develop to understand where paths should go rather than specifying them in advance. So there might be some other context reference to think about there.
Yeah.
Maybe Beth could pick that up with you afterwards.
Yeah, nothing interesting.
Some comments about the pause tool that people like that, like those ideas. Gillian, there's quite a long one here from you. I wonder if you might want to unpick that and just unmute your mic and perhaps ask that question.
Sorry, I was trying to squeeze my lunch in. I do apologise.
Sorry to put you on the spot.
No, it's okay. I think it just sort of, I mean, it's all just so fascinating, isn't it? And it all starts overlapping. Just, we're doing a lot of teaching through our organisation, as I'm sure most are, and we do talk to this quite a lot with regards to sort of trying to open a hopefully safe and open conversation around are workarounds always bad? Are they always bad things? So rather than beating people over the head with the policy and saying, do this better or do this right, it's actually what we should be doing is going back to the beginning of the process and saying, actually, is our process at all fit for purpose? Because, we are, as humans, we are almost pre-programmed to take the easiest path, aren't we? As whoever had commented about the architectural I flash up a picture of what I'd heard them called elephant paths. I don't know whether that's true or whether that's just something that's local to us in the Midlands. Not that we that, you know, people will always take the easiest route from A to B, and they'll figure out the best way, the way that makes sense to them. And I think what's interesting from your research is that actually that's not the same for everybody. And it is actually interesting to sort of see that different areas doing the same process will have different ways of doing it because they've got different priorities and different stresses. And that's really fascinating. Thank you.
Yeah. I mean, I think the interesting thing there is that, I mean, obviously it's great to hear that in some organisation they're talking about workarounds, because that's strongly what came through from the focus group. To improve and learn, we need to be talking about them, because one, the workarounds are unlocking some insights into what's really going on and how we're coping with that. But I think the last thing we want to do is only find out about workarounds when they're involved in an error or an incident, and then it's put onto the person when everybody's using them. Yeah.
There are some more questions coming through, and they're really exciting ones. So we can save the chat, Debbie, and send it to you in case it might be helpful.
I'm very happy. If anyone wants to get in touch, I'm obviously happy to chat and help. So thank you.
But can we thank you once more, and thanks everybody for joining us today to make such a great seminar. Thank you.
Thank you.
Bye, everybody.